Hello, my name is Sara and I am the founder and chief executive officer of ALEX, the Leukodystrophy charity, or ALEX TLC. We support sufferers of the genetic leukodystrophies, and I'm talking today about our experience in applying to include the most prevalent leukodystrophy, ALD, within the UK newborn screening programme. Adrenoleukodystrophy, or ALD, is an X-linked disorder causing mutations at the ABCD1 gene and the body's inability to metabolize very long-chain fatty acids. These build up and cause deterioration of the white matter in the brain and spinal cord, causing progressive deterioration of all voluntary function. Males are more severely affected, although a majority of females will experience physical symptoms to a lesser degree, usually by the age of 50. There are two distinct phenotypes: cerebral ALD, which is terminal and most notably affects boys between 4 and 10, with a growing number of adult males reported over the past decade, and adrenomyeloneuropathy, or AMN, which primarily affects mobility and can also progress to the cerebral form in approximately a third of cases. The symptoms of a small number of patients with cerebral ALD arrest spontaneously, the cause of which is unknown. The majority of males with ALD also have adrenal insufficiency, life-threatening yet readily treatable through hormone replacement. Treatment by bone marrow transplant, or more recently gene therapy, is successful in a majority of cases if disease progression is caught early enough through MRI scanning. In other words, you have to know you have the gene if it's going to work effectively. Currently, this is only available for those under the age of 18 in the UK, although there is growing pressure to extend this to adult males following successes in other countries. So ALD entered our lives back in 2001. My eldest son Alex was born in 1993 with no concerns. He achieved all his milestones and family life was very normal. In 2000, his brother Aidan came along, and it was shortly after this that we started to see problems with Alex, who was 7 at the time. His behaviour became increasingly challenging, with sudden outbursts of temper, not doing as he was told, and generally being uncharacteristically naughty. Although in the back of my mind I knew there was something wrong, it wasn't something that could be explained adequately to a GP, and we tried really hard. So his behaviour was put down to sibling jealousy. However, the behaviour continued. His schoolwork and handwriting declined. He had been top of his class. And in September 2000, his school reported he was squinting at the board and doing the wrong pages of homework, as well as showing signs of not hearing properly. We went for eyesight and hearing tests, but they came back normal. During the next few weeks, things started to become more serious, and I was called to school again. Alex was getting lost, couldn't find his way to the toilets, and was often found just standing in the middle of the playground, very confused as to what he should be doing. It was a terrifying time, and these incidents were being replicated more and more at home. We were referred for neurological tests just before Christmas 2000, by which time Alex could not walk in a straight line or see clearly. In mid-January 2001, 6 months after raising initial concerns, Alex was finally diagnosed with adrenoleukodystrophy, or ALD. We were told that the skills he had lost were gone for good, that he would continue to deteriorate, and probably had between a year and 18 months to live. We were told to take him home and give him the best life we possibly could with the time we had left. By April, Alex could no longer walk, and talking and eating were becoming a struggle. Following a genetic test, my younger son Aidan was also confirmed as having ALD, and I was identified as a carrier. Having never encountered disability or even serious illness before, we have been plunged into a new and very scary world. So what do you do next? As with most families dealing with similar situations, you just get on with things. The fact that we have one son losing abilities on a daily basis and another becoming more mobile and vocal at the same time was not easy. However, the myriad of issues this brought up, having to move home, endless hospital appointments, disability equipment, home care packages, educational needs, finding a nursery placement, all kept our minds off the devastating reality that was our lives now. Within a year, Alex had lost all abilities and was blind, tube-fed, and in a wheelchair, with muscle spasms that kept him stiff and uncomfortable on a permanent basis. Life was difficult, and learning how to implement health and social care systems to enable us to live the best life possible was a seemingly never-ending challenge. Meanwhile, Aidan was monitored rigorously for any signs of ALD by regular MRI scanning and taking Lorenzo's oil therapy alongside a very low-fat diet in the hope of preventing symptoms. In 2008, we were told that Aidan's latest scan had shown signs of ALD. However, the good news was that he could have a bone marrow transplant to stop him becoming like his brother, a treatment that sadly was unavailable for Alex. It only works if done before symptoms become apparent. He had a successful transplant in May 2008 and is now a healthy and very typical young adult in his second year at university and working part-time in our Alex TLC charity shops. So what was the impact of living with this horrific disorder on us all? Fortunately, I was on extended maternity leave when the diagnosis happened, but I could not return to work with my new caring commitments, so I had to rely on state benefits for our household income. The pressure of our new situation caused my relationship to break down irreparably, and we split shortly after the diagnosis, my partner at the time unable to cope. As many who live with rare conditions will appreciate, your friendship groups change radically with these diagnoses, and I lost many supposedly close friends, although these were eventually replaced by much deeper and more meaningful relationships. Not surprisingly, and not uncommonly, I was diagnosed with depression and took medication for many years. Sadly, after a 12-year battle with his symptoms and many happy memories, Alex lost his fight just before Christmas in 2012, aged 19. Following his death, my own physical health deteriorated rapidly, and the cost of managing Alex's physical needs culminated in severe arthritis and a hip replacement. The repercussions of living with ALD are far-reaching, not only for myself but also for Aidan. Although he is free from the worry of developing ALD like his brother, he has to cope daily with life-threatening adrenal insufficiency, as well as the threat of further health issues later in life and the repercussions of aggressive chemotherapy. Add to this the psychological issues he has to cope with, fighting for attention, Alex's needs always having to come first, feelings of survivor guilt, living with an unseen illness. It has not been an easy life for him. Following Alex's death, we were quickly plunged into debt. I was lucky in that I had my charity work to fall back on and was able to transfer to a paid position within Alex TLC. Without this, we would have been left in extreme financial difficulty and would have lost the family home. Not many employers want to see a 12-year gap in a CV, let alone deal with a bereaved parent in the workplace. So listening to my story, it seems logical that newborn screening is the magic wand that everyone with ALD needs. The condition is treatable, but only if identified early, so should be a no-brainer. Alex TLC have been querying with our medical specialists for years about getting ALD on the newborn screening programme. However, they warned that the argument that bone marrow transplant was a successful and effective treatment was not good enough at the time, and efforts would more than likely fail. In 2013, during a discussion with our medical advisor, Professor Colin Stewart, he suggested that the time was finally right. ALD had recently been added to the screening programme for New York State. Bone marrow transplant survival rates had improved and a robust test had been developed. A pharmaceutical company had noticed our work, and we successfully negotiated that they would help us in our efforts towards newborn screening, specifically in funding an economic survey. This would prove to the NHS the cost benefits of screening for this condition. All our ducks were in a row, so work began in earnest. The first step was to form an MBS committee. We gathered together specialists, laboratory technicians, and experienced newborn screening protagonists from around the UK and the world. We also looked to peer patient groups for their experiences. We met with a representative from the National Screening Committee to understand more about NSC criteria, the ethics behind their decision making, and how they might look at a complex condition such as ALD. Over time, we collected together as many up-to-date and relevant clinical papers as possible to demonstrate incidence and treatment outcomes, and our laboratory scientists worked on validating the methodology of the test used in the US to ensure it would work with UK equipment. We also commissioned SHAR, the School of Health and Related Research at Sheffield University, to complete an economic survey. The NSC decided to change our application process in 2015, and we were invited to pilot this new procedure. The new application form was challenging, with severe limits on word counts and the clinical papers that could be submitted. A flowchart also needed to be developed to illustrate the potential numbers and outcomes involved. One of our biggest dilemmas was whether or not to ask to screen just males or males and females. ALD is an X-linked disorder, so females do not suffer as severe symptoms as males. It was a tricky question, but we decided there was more chance of success if we only included males at this point. With the help of our MBS committee and specialists from around the globe, an application approved by all was completed and submitted in June 2016. In April 2017, the decision came back disappointingly as negative. We needed more robust data on incidence, test reliability and false positives, which would not be forthcoming until there was more US data published. By then, screening had been introduced to 4 more US states. As the AMN phenotype is not treatable and adults are currently unable to access bone marrow transplant in the UK, the NSC had concerns around diagnosing this cohort from birth. They also seemed to dismiss the importance of identifying the 80% of males with ALD who would also have life-threatening adrenal insufficiency. The NSC considered that the outcomes for BMT and the identification of individuals suitable for BMT was inadequate, potentially leading to unnecessary treatment. They were also unhappy with the patient outcome data following BMT that we had supplied. This point was particularly frustrating, as the only evidence available included a significant number of individuals who had been transplanted too late for best outcomes due to late diagnosis, which newborn screening would remedy. The economic review was also challenged in terms of evidence base. Specifically, there is not enough certain evidence informing the assumptions of the model to feel confident in its predictions. It was really disappointing for all concerned, and everyone felt that our evidence had not been looked at properly, with some of the NSC conclusions cherry-picked rather than rationalised. We were unhappy with some of the reasoning behind the decision, so we asked the NSC some specific questions around this and determined that no ALD specialist or patient representative had been included in the evaluation group. We felt the evidence could not be comprehensively reviewed without specialist expertise. The importance of identifying other family members was also an area we felt was key, but due to ethics, largely ignored. The NSC did concede that ALD would be added to the list of recommendations and reviewed as part of the regular update cycle. We have had nothing in this respect, and ALD is still not included on this list. To date, we are waiting on a response from the NSC. So next steps. We looked carefully at the NSC review document and the feasibility of accessing the evidence they wanted. More US evidence has been published. They now screen for ALD in 14 states, with 13 more mobilising efforts or getting ready to start. ALD screening is also being considered nationally and has been added to the RUSP. Furthermore, the Netherlands have approved the addition of ALD to their newborn screening programme. A chart study to determine BMT outcomes in paediatric ALD patients is ongoing, with results expected later this year. Additional evidence around adult BMT, gene therapy, and the importance of early diagnosis for adrenal insufficiency will also strengthen our argument. We are also currently looking to commission a study exploring whether individuals with ALD or AMN would have wanted their diagnosis from birth, and comparing results to the opinions from the general public. However, many key issues that the NSC review document brought up were issues that we have seen with other rare diseases. We knew challenging these issues was not a project we could undertake alone, and this prompted us to question if there was some collaborative work that could be done. Working with Genetic Alliance as the case study for their newborn screening patient charter, we helped raise this issue last summer, appearing on various national news programmes. Excuse me. So I would like to think that the current pandemic has heightened global sensitivity to the fragility of health. And as a rare disease community, perhaps we should take advantage of this new perspective. The world is looking to science to prevent and cure an unprecedented viral phenomenon. Is now the time to push the health systems to prevent those conditions we can treat, or where genetic knowledge is key for reproductive choice, in order to unburden health systems for the future? Do the criteria and tools used for decades in making health decisions really apply in today's world of genome sequencing and gene therapy, or is it time to promote change together? Sorry. Thank you.